Good afternoon. My name is Will Marshall. I'm president of the Progressive Policy Institute, and I want to thank you all for joining us here at lovely, sorry, have I got it wrong? Is that better? No, that's not better either. How about that? There we are. Okay, I'm going to start over. I'm Will Marshall, Progressive Policy Institute from Washington, D.C., but we're very happy to be back in here in Iowa for a continuation of a series we launched of idea forums, focused on the big decisions facing the American people in 2020. But it's great to be here at Principal Park. It's a stunning location. I understand, unfortunately, because of the unseasonably cold weather, they've canceled today's, was it doubleheader? So there's a game.
Tonight's game tomorrow.
Tomorrow will be the doubleheader, but don't worry, we have decided to extend this panel for 4 hours so that you all can get what you paid for and use those rain checks. But seriously, it's a marvelous venue, and really happy to be here. I want to, at this point, really thank Jeff Link, who is our Iowa partner in this series of forums. And without Jeff, of course, we wouldn't be able to produce such a fabulous crowd of folks from here. PPI is a think tank that's in Washington, but we've got some history in Iowa. We kind of hear a lot, and through our connection with the Democratic Leadership Council, if anybody remembers that, I know Phil Weiser remembers it. We had some great relationships with Iowa Democrats down the years, so it is wonderful to be back here. Our first forum was in December with Tom Vilsack, Patty Judge, and Representative Chris Hall. And it was on ending what we call the nation's public investment drought. We're not investing as a country anymore, basically because our fiscal picture is all jammed up. We can't figure out how to dig our way out of a terrible debt and deficit hole we're in, and therefore it's really hard to invest in the things we need to invest in. But today our topic is equally as difficult and equally as important, and it's health care. And the title is Progressive Alternatives to Nationalized Healthcare, which sort of tells you that we have a point of view. We don't come in here pretending to strict neutrality. We think that it's important for us to get this issue right. We have views about what that means, and we'll talk about that in this panel. But it is great to have these four in Iowa, because what we found in December when we launched the series with Tom Vilsack and company, Iowans show up, they ask really tough questions, they don't take glib answers. It's great to talk to folks who are taking seriously their responsibility for helping vetting an enormous field of candidates running in this 2020 race. Healthcare dominated the midterm elections, and it's still the top security issue. If you look at all the polling, people, there's Tom Miller. Tom, welcome. Good to see you too as well, a longtime friend from back in the day. It's still the top economic security concern in the country, despite what looks to be on the surface a very strong economy. And we know that despite having fought the battle to prevent the ACA from being killed, we have a lot more work to do. You can't just rest on those laurels. We have 20 million more people to cover, at least. It's actually a larger number than that, but approximately. And we have a highly inefficient and hyperinflationary medical system, delivery system. It costs too much. It doesn't deliver care commensurate with the extraordinary cost growth that we face. It's too expensive for everybody in the system. We have to really focus on how to bend down the cost curve, as we also want to expand coverage. Now, despite the rebuke that the Republican Party suffered in the midterm elections on health care, which was probably the dominant issue, the president has renewed his crusade to undo the ACA and has talked about making Republicans the party of health care. Good luck on that. But he's, it triggered immediately a funny Alphonse and Gaston routine among Washington Republicans. You first, Mr. President. No, after you, produce the health care plan. Neither side really wants to do it. Now the president has decided, well, nobody has to do it until after the election, which seems a little late. But this party has spent 9 years naysaying on the ACA, on Obamacare, and is ready now, I think, to file intellectual bankruptcy because it's been unable to come up with a positive plan of its own. And in the meantime, we had yesterday Senator Bernie Sanders dropping a new version of his single-payer or Medicare for All bill in the Senate with some Democratic support. And I would say that maybe the main force driving the debate in the direction of something like Medicare for all or single-payer plans is not so much Bernie Sanders as this Republican refusal to say yes to covering all Americans. We do want to talk about this plan. We want to talk about alternatives to this plan. That's the goal for today. One thing I would observe is that Democrats want a lot of trust, of public trust in the midterm election last year by fighting for ACA, by fighting to protect people with pre-existing conditions, their access to affordable health care. And one of the problems with leading all the way from where we are today to a single-payer or a nationalized health system is that it ironically does away with the AC. It does away with private coverage. We think that's a problem. And we don't think that Democrats want to squander the goodwill and trust of the public that we won in this last election by now telling lots of Americans, well, after all, we're going to have to, you're going to have to give up the coverage that we bought in the last election to make sure you could hold on to. So we at BPI really want to see Democrats and progressives keep their sights on the goals that we share, and that is creating a universal, affordable, and innovative health care system. We're proposing, and you've got a short version of it here on your table, a uniquely American approach that combines the best of public and private provision of health care to create the kind of system that we think we need. My final point is to say this. Too often in this debate, we're just arguing about how you finance universal health care or how you don't finance it if you happen to be a Republican. But this debate is really missing the critical dimension. That's how to get the cost down. And we think that you've got to deliver better health care to people at a lower cost. That's the real object of this whole health care reform debate, in our view, and from our point of view. Producing better outcomes at lower prices has to be the first principle of any progressive health care reform. So with that, I'm going to just introduce our speakers and get the program rolling. Governor John Hickenlooper, thank you for joining us, Governor. He's one of our favorite friends in Democratic politics. He's been one of the most creative and accomplished governors in America. And you all probably know the story of somebody who lost his job way back in the 80s and started a brew club, and that launched him on an truly incredible political career, twice elected overwhelmingly mayor of Denver, then becoming the first mayor of Denver in over a century to be elected governor and overwhelmingly re-elected again. So he's been a popular favorite in Colorado, and no wonder on his watch, Colorado jumped from 40th in job creation to first. But we've just watched from afar over the years as Governor Hickenlooper has really been a great innovator across the whole spectrum of issues: education policy, workforce development, energy. We've been writing about it, documenting some of that at PPI. He also has strong opinions on healthcare, helped expand the ACA in Colorado and push healthcare delivery out to the rural areas that needs it so badly. So, and did I mention he's running for president? This is a candidate. It's not a candidate for him. It's an ideas for him. It's a policy for him. But we acknowledge that he's out there running for the prize. Teresa Greenfield is from Des Moines. She's a Des Moines business leader, a mother, and a self-described farm kid. She's been an urban planner and a home builder, and now is the president of a commercial real estate company here. As you all know, she ran for the 3rd District congressional seat last time around. That's about access issues. But I am told by my friends here that we will be hearing much more from her. So we're really glad that you could, that's what I hear. But in any event, we're so glad that you could join us here today and give us a point of view. And we know you've been hearing from people in the 3rd District and Des Moines, and we'd love to get your view. And then finally, my good friend and colleague, Ariel Kane, who runs BPI's healthcare policy work and can go deep on this issue. And she came to us from Deloitte, where she was the director of their healthcare policy work, and is doing that for us, and has brought great energy and fresh vision to our work on healthcare policy. And like a lot of people, we've been at this for a long time, so it's great to have a new set of eyes to help us do all this. So without further ado, I'm going to ask Governor Hickenlooper to start us off, and then Teresa and Ariel will give responses, and then we'll have a little conversation here, and then with plenty of time, we'll kick it all to you. So, Teresa, over to you.
It's always difficult to get the sequence right. I want to recognize again, former Representative Phil Wise is here, and Tom Lowe, the AG, Polk County Auditor, Jamie Fitzgerald, and Claire Kelsey, the State Senator. As a former elected official, I want to make sure I always recognize those people that are putting in the hard duty. I'm going to do just a quick framework of where I come from on healthcare. I have an obligation to say why I'm running for president, just to make sure when you go home you're clear about it. I'm running for president is really because I think the country is at a national crisis, and a crisis of division. I think a big part of that has been what President Trump has done in every regard possible to divide us, but especially around healthcare. And if you'll remember, I was one of the people with the governor of Ohio, and Governor Kasich and I really joined arms and worked very hard to demonstrate that a Republican and a Democrat could both find pathways to improve the Affordable Care Act, and it wasn't necessary to be repealed. And that is when Senator John McCain said that he thought we should look towards the governors before making final decisions on how we legislate health care, because the governors implement it. He was looking right at myself and Kasich. I'm running for president because I look at it at the country, and I spent the last 16 years, both 8 years as mayor, 8 years as governor, trying to bring people together, get them to lay down their weapons, and work towards common ground and find common solutions to these most vexing of problems. And we've been able to do it with the environmental community, with the oil and gas industry, to address methane regulations. I can give you a long list. But healthcare is a big part of it, right? And I've spent a lot of time in the last couple of months talking about how do we get America working again. And America works best when everyone has healthcare. In Colorado, we got to almost universal coverage. We got to almost 95%. We expanded Medicaid. I think it's one of the best things we did, not only for the moral purpose of keeping people healthy, but our businesses saw an immediate response in terms of their workforce. There was an economic pickup. Within 6 months or 9 months, I think it had certainly a significant role in how we turned our economy around. We also created one of the most innovative exchanges in the country. And we made sure that we got, in Colorado, we're still trying to catch up to Iowa. We only have 64 counties. We'll get there someday, but we only have 64 now. But we made sure we had private insurance companies in every single one of those counties. And worked very hard to make sure that people, even in some of the more remote counties, had reasonable choices. Now, that's not always easy to do, and certainly on a national level, I think you're going to have to look at a different level of subsidies. I would also point out that we worked very hard in Colorado to recognize that prevention ultimately has to be part of the solution. And we've created something called Colorado the Beautiful, that within one generation, within 20 years, we would make sure that every kid in Colorado was within a 10-minute walk of a green space or a park. We would really begin to focus on outdoor recreation, which turns out to be a good thing for economic development, because most of those outdoor recreation companies, the smaller ones, don't like to be in big cities. And most good governors are trying to spend their time frequently getting businesses to locate into the more rural parts of the state. And getting people out and hunting, fishing, hiking, biking. I think RAGBRAI's a pretty good example of a way to mobilize people into outdoor recreation. That is clearly one of the long-term goals that we're all going to have to strive towards. I grew up, my mom was widowed a couple times. Before she was 40, I was 8 when my dad died. And we learned how important it was that healthcare was a right, not a privilege. And when I was in college, I helped a friend of mine start a federally sanctioned community health center in Middletown, Connecticut, back in 1973. And I actually wrote a letter to the local newspaper, the Middletown Press, in 1978, saying that healthcare needed to be a right and not a privilege. I think Senator Elizabeth Warren was still a Republican back then, I'm not sure. Just kidding, Senator Warren, that was just a joke. But we were, that is, I think, the basic premise that I've approached this from, is how do we make sure that we cover everybody? And certainly what we did in Colorado by innovating within the exchange, expanding Medicaid, but we're going to have to do more than that on a national level. Obviously some sort of public option, and people talk all the time about Medicare for all, and I give Senator Sanders a lot of credit for bringing this issue to the public forum with a great deal of clarity. I disagree that we can, in a very short period of time, transfer or transform our system into a single-payer system. When you have north of 150, maybe even 160 million people in this country that have insurance with private companies, and most of that insurance comes through their business, and even when you account for the fact that so many people are unhappy with that insurance and would like to replace it, there is a large number. People estimate 80 to 100, maybe even 110 million people that are happy with the coverage they have. And in this country, I can't imagine how we would go, how the government would go forward taking that insurance away from people. But I do think we need some sort of a public option to get universal coverage, and that could well be an option to buy into Medicare, or maybe some combination of Medicare or Medicare Advantage. It could also include people who are on the lower end of the income spectrum who couldn't afford private coverage to be able to buy into Medicaid. And there's some different opportunities and cost benefits there as well. But I want to finish just to say, let's assume that we're all agreed that we're going to get to universal coverage. Then the real question is, how do we control this inflationary cost spiral that has been vexing us for the better part of 30 years? It's not quite double, but the rate of medical inflation is very close to double our normal economic inflation. And that's been going on year after year after year. As Warren Buffett says, the power of compounding is working against us in that. And there are a number of things we can do. One is transparency. It's been long overdue that we, if you're taking your kid to get their tonsils out, and you're deciding whether you're going to go to this hospital or that one or a clinic, you should be able to see on your cell phone what that cost would be. And some measure of the quality, the outcomes that you would get. Just like when you're, it sounds silly, but when you're looking at a restaurant, you can get appraisals of quality based on many, many customer responses. The notion that we can't have those prices available from hospitals and clinics is vexing. And I think the excuse we heard most frequently in Colorado was that the problem, it was just too complicated, too many variables. Well, we did a little research, and Walmart has about 130,000, 135,000 different products. You include sizes in different colors, and you're getting close to 400,000, 450,000 SKUs, and they can tell you the price of every single one. And I think this is one of those places where we're just going to have to step up and address it. The second thing is, I think we're going to have to move towards a more closely regulated approach to our pharmaceuticals. And I'm not someone who believes that demonizing the private sector is going to solve anything. Right? The drug companies are going to have to be part of the solution. If you look at some of the estimates now for Alzheimer's and other types of dementia, they're estimating that if we don't find a cure, and there is nothing in the near proximity that is on the horizon of medical advance, but the dementia could be costing us as overall $1.5 trillion in today's dollars by 2050. This is an issue that affects everyone, and we're not going to solve it without figuring out how to make sure that we blend pure research and applied research in pursuit of these pharmaceutical discoveries. That being said, There's no reason. I was at a house party in Iowa, I guess 3 weeks ago, 4 weeks ago, and a woman described how her sister in Canada, also they both had diabetes, and the woman I talked to spends 30 times more per unit to buy insulin in this country than her sister pays in Canada. And I can guarantee you most of the scientific research that made that insulin the miracle drug that it is, I'll bet most of that research that made that miracle drug happened in the United States. And I think it's this long time that we should be able to compete and be able to get the same low costs for our pharmaceuticals as other countries do. And the last thing, this notion of paying what they call fee for service, that we just, what happened, we switched healthcare from being what was largely considered a public service, and it was run by nonprofit hospitals. It transformed in my lifetime to becoming a business. And businesses go where the money is. I don't like John Dillinger. The bottom line is that if doctors, and every doctor I know is committed and dedicated to maintaining and improving the health of their patients. I'm a big pro doctor, but the system is designed to make money. And if a doctor is able to prevent a patient from developing a lifestyle-based chronic disease like hypertension, right, leads to heart attacks, if they can prevent that, they get no benefit. But of course, if that person has a heart attack, has a medical emergency of any kind, the same is true with diabetes. If that happens, then of course the system, money rains down. And we have to change that from just paying for every time we need health care to really figure out how do we pay to cover someone and maintain them in a healthy state of body so that we're not always having to play catch up and pay these huge costs with the result from people getting into healthcare emergencies. I recognize you're all here part of this healthcare system. I also recognize that there are so many different self-interests that finding resolution whereby we can not only get to universal coverage, but we can begin to arrest this ridiculous inflationary spiral is going to be very hard. But ultimately, everyone's going to have to give a little bit. And I think that's a large part of what we've done in Colorado on all kinds of different areas. We've been able to go sit down with people, as I said before, get them to lay down their weapons and actually find compromises and move forward. And I think there's no better place that demonstrates the necessity for that approach than healthcare.
Well, I just want to thank Governor Hickenlooper for joining us today and have this conversation. And Will and Ariel, thank you for inviting me. I am not a policy wonk. Maybe some of you know that about me. But I was invited today to be able to provide some insights and just some anecdotal stories from a small business perspective, and certainly as someone who has been a candidate for Congress and had the opportunity to move around the 16 counties of the 3rd District and hear a lot of different perspectives on priorities. And everywhere I went, whether it was small businesses or in a house party, healthcare was always the #1 priority. So before I tell a couple of those stories, I also just want to say it's great to be in Iowa, and thank you for coming here today. I just think that we have such a great opportunity as first in the nation to really push our candidates, ask a lot of questions, show up and support them. But I also think that we have the responsibility to add a little Midwestern pragmatic thought to the grand ideas and the policy solutions. And I think that's what today's conversation is about, is encouraging more ideas, more conversation to get to where we all want to go, which is care for everyone. Rural, urban, wealthy, poor, it doesn't matter. And there's just a lot of hurdles that we need to get over to accomplish that. As a small business person, are there folks in here who own their own small business? Please raise your hand. I know some of you. Yeah, of course you do. Yeah, that's right. I will tell you, health insurance renewal day, the day when you sit down with your broker, your health provider, and take a look at next year's premiums, is anxiety filled. It's horrible. I do that every year on behalf of the company I work for, and we have about 300 tenants, mostly small businesses, who do that every year also. And it's awful. It always goes up, the cost. And small businesses are stuck trying to make decisions on behalf of their employees. Should I raise the deductible? Can they afford a $1,000 deductible? A $5,000 deductible? And yet we know throughout Iowa and this country, so many people can't even afford a $500 repair to their car, much less a $500 medical emergency. So this goal that we're all working towards to get everyone affordable, quality, accessible health care is noble and one that we have to continue to debate and move forward on. So I can tell you a lot more stories about that. As a candidate, of course, I always thought my main goal was to listen, to really get out there and encourage people to tell me what it is, if I were to represent them, that they'd like me to focus on first. And again, healthcare came up every time, number one, over and over again. Lower prescription drug costs. Expand Medicare, Medicaid. But in particular, the 15 rural counties of this district had unique concerns about how far they have to drive to a hospital and the kinds of services their hospital will provide. I'm not sure if you know, but so many hospitals and counties in the state are dropping maternity care. So some small hospitals may provide it. Many of them have dropped it. I think we're down about 50% of the hospitals in this state that provide maternity care. So if you have to drive 60 minutes to get care, you've got health concerns and anxiety that you don't need. One of the things, though, that always delighted me and knew we were headed in the right direction was when I talked to folks who hated Obamacare. They hated it. It came out in 2010 and they were against it. But they were at a Democratic meeting. And why? Because it was 2018 and they loved that they no longer had to live with anxiety and fear that they would lose their health care because they had a pre-existing condition. Or their grandchildren were able to stay on their parents' health policy and get through college and get started on their careers without that fear of what does a medical crisis do for a young adult who doesn't have assets and can't make enough money at that point in time to cover those costs. Those folks inspired me, and it reminded me that we are on the right path as we continue to think about what are our next steps. How do we build on what the ACA has provided to this country and to Iowans, and what are the next steps as we move into 2020 and hopefully take back the presidency with some fine candidates like Governor Hickenlooper. So those are my stories. I'll chime in more as we go on today, but I want to give Ariel some time to tell us more about PPI.
Thank you. This is my first time to Iowa, and I'm so excited to be here and to be talking about my most favorite topic, which is healthcare. I can think of a number of things to say, but I wanted to just, healthcare is complicated, as we all know, and it's very deeply personal. And I think sometimes that gets lost at the policy level because we talk in, graphs and how much things cost and, but when you're sitting in front of your doctor and you're having a really hard decision about your life and your health care, like that should never be lost. And, when the ACA passed and a few people were not able to renew their health plans, and I could tell you why. I could tell you that they didn't, have the 10 essential health benefits, or, they didn't have an out-of-pocket max or whatever. But those people felt like something was taken from them and were angry that they were told they could keep their health plan and then they couldn't. And I don't want Democrats to forget that. I think that people want choice, and when you tell everyone that you know the solution for them and it's a one-size-fits-all, and you force them into one specific thing, I don't think that ever goes over well. And so we're here today to sort of encourage dialogue around, more than just one size-fits-all healthcare plan, and to try and have a robust conversation around what does or is there more than one option? How do we get to the goals that we want, which is universal coverage, affordable care, and higher quality and more innovation for everyone? So that we have a paper in front of you. It's just a very brief outline of a proposal that we're working on, and we love, everyone else's thoughts on the matter. We'll, in the coming months, we'll put out a more comprehensive proposal that builds on the ACA, because we do believe in what the ACA started, but we know that 28 million people are still uninsured. We know that even people who have coverage still can't afford their care. And we know that even when you have coverage and care, it can still be the most annoying thing in the world to try and get an x-ray sent to another doctor across town, and for some reason that seems impossible. So that's what we're here to work on, and that's what we're here to talk about. And with that, I'm going to punt it back to Will.
Well, thank you all, and great comments and points. I want to follow up on this question of rural health care, because you mentioned it, and how difficult it was to make sure you didn't have any bare counties out in Colorado where there's not even one private provider. And you also mentioned the public option. So, and I know that's been, you've mentioned rural health care too, it's a huge issue in Iowa, obviously. So how does it work? How do you induce, or how do you get the private insurers to go out to sparsely populated places, stay there, and provide an affordable service to people? And does that require, the backstop of a public option, a Medicare buy-in proposal, or what's the key to getting those private actors to come and stay in rural places and deliver?
The trick for us has been to, and I don't want to misstate, we still have serious issues around cost. In some of the more isolated parts of the state, people will pay literally 20–30% more than they would for the same procedures. And we get that's unacceptable. It's just within the given system right now, we weren't able to provide sufficient subsidies. We have a regional network of about 29, we call them Affordable Care Collaboratives. There are clinic systems that try to fill in the gaps where it's harder to deliver health care, and that allows insurers to feel with some more security that they will be able to, private insurance companies want to make a profit, and they're not going to go somewhere and invest in building a business if they end up losing money there. Now, we've been lucky to have some pretty reasonable corporations in the insurance side of things, but you look at the overall costs that we're dealing with, and in some of these rural, especially in Colorado, our mountain communities, we need different tools and some better tools. One of the things we worked on very hard when I first took office, we got a foundation grant from, I think it was the Susan Buffett Foundation, but for women's health care, for women to be able to make their own decisions about when to have a family. So we provided long-acting, reversible contraception, so things like Norplants or IUDs to 15 to 25-year-old young women, ostensibly all over the state. And it was very successful. I know there's some issues in Iowa around this issue, but I think it's worth bringing up again that in Colorado over the last 8 years, we've reduced teenage pregnancy by 60% and teenage abortion by 60%. And those are real numbers, although we did have gaps, and we are still working on some of those rural areas, because that's the most difficult place to fill in some of these most necessary services.
Yeah, sure. One of the things I did when I was running for Congress is I took the opportunity to call every single hospital administrator in the district and left a message and reached out and said, how's this Medicaid expansion thing working out for you? And most of them called me back, which I was thrilled with. And they took the time to tell me overwhelmingly how much it probably helped save their hospitals. And that's not to say our hospitals are out of the woods yet. They aren't. But they were receiving additional funding. They had motivation to provide better quality, or at least to track that. And they were finding ways to collaborate with other services in the community, other medical providers, to decrease rates in which people were coming back to the emergency room, lower the rate in which people were being admitted to the hospital, all very costly services. So again, I just go back to we're heading in that right direction. And more people, and we saw that in the 2018 election, are on board with that. We do need more help here in Iowa with our rural hospitals, and I'll leave that for folks like you to suss out some policy for us. Thank you.
Well, let me ask a more political question. We, as I said, Senator Sanders introduces Medicare for All bill this week, and this has become a pretty, tough issue for the Democrats. A lot of people are for it at a very high level of generality. When you probe a little deeper, sometimes some of that support melts away. But we had an actual real-world test of this in 2016 in your home state, Governor, when Colorado had a ballot initiative, a referendum on a single-payer approach. And I believe Senator Sanders was out in your state, leading the charge for that. Can you just tell us what happened? Because that's the last time I'm aware of that the issue was actually put to a large electorate.
Thank you. It got crushed. The risk of that large an investment in such a short period of time scared people away. And I don't think it's fair to say that that means it wouldn't work, or that it's as evil an idea as some people say.
How much did the insurance company pay?
That's a fair question. There was a lot of money spent on both sides of that issue. That's why I'm defending. I'm not saying it shouldn't be taken as a true reflection. It should demonstrate, when you have so many self-interests, that moving into that system would be a very long and difficult battle. And I think my preference, and again, I recognize that there are a lot of opinions in this room, but I think incrementally, if you allow people to buy into, and I think that I'm getting more and more convinced that we've got to keep it simple so people understand it. But I think for lower income people to be able to buy into Medicaid, and for other folk, older folks to be able to buy into Medicare and to look at some of the benefits of Medicare Advantage, I think incrementally, if it's really as good a system as many people think, that as more people go into Medicare, it scales and it actually creates significant savings, that will attract more people. And then you'll have more scale, and then you'll get more savings. You could get there pretty rapidly in an evolutionary way. I don't think trying to do it in a revolutionary way is going to be very successful in this country. Again, my opinion, recognizing that I pissed off half the room.
Well, thank you, Andrew. We're going to turn it over to Ruth in just one second. Let me just get a last question into Errol. Errol, would you just describe, because I think all of us understand that the ACA is necessary as it was. And remember, it extended coverage to 17 million people who didn't have it before, not to mention the pre-existing protections and letting people like my daughter stay on here until 26. I do appreciate that.
I did the same thing.
Yes. So when we know that we got to go further, we know we need to do more. We need to do more to control costs, as you pointed out earlier, and we need to expand coverage. So just quickly touch on our cost control ideas and in the Medicare buy-in that's part of the architecture that we're proposing.
Yeah, so I think that if you talk to people about what the goals of Medicare for All is, if it's to bring down costs, because Medicare has a fee schedule that has been more effective at controlling costs than commercial health plans, you can take those same prices and you can apply that to the commercial market. That's what Medicare Advantage is. And so there are lessons that we can learn, and so our idea is, why not have stricter price controls in the commercial market? Why not have caps on how much you can charge if you show up to a hospital for an unexpected surgery or an ambulance ride? You can put caps on that. That is a policy mechanism that exists. And so also, as I get my health insurance through my employer, who's sitting right down there. And what that means is that I get a subsidy that amounts to about a 30% subsidy for my health insurance. Why wouldn't anyone in the commercial market, you know, or any in the individual market, why wouldn't they be eligible for similar subsidies? So we can expand subsidies in a way that's equal. And so just because you're in the individual market, it doesn't mean that you pay higher costs. And then finally, I think that there are people that are uniquely hurt, and it tends to be older people and people who don't have employer-sponsored health insurance. So why don't we target, like you said, go after the people who are really hurting and try and give those people an option to buy into Medicare, where they might have more stricter price controls and lower copays. So that's the framework of what we want to, we're looking at the ACA. We think it was a good place to start. We also see that, people have been attacking it for the last 10 years. We want to build on that success, knowing that there's still 28 million who are uninsured and many people who can't afford their care. Yeah.
Will, you keep finding really smart, young professionals to drive your ideas.
On top of that, the only thing I'd add in there, there's within the exchanges a necessity called something called the high cost pool, which in most states doesn't exist. But it allows, what happens is that many of those exchanges are small enough so there are few people with chronic medical issues that are recurring and very, very expensive. Those high cost individuals end up raising up the premium cost for everybody. And it actually makes a lot of sense to create a special pool to allow that coverage to allows government to take on some of the burden of that coverage, which allows a more competitive price rate and actually gets more people into coverage, right? Which again lowers prices for everybody. So it's right in with what you were describing.
Well, thank you. And I think these last several comments all underscored there are a lot of roads to get where we all want to be. And I think it's important that, and appropriate that we're in a big presidential election, big election year cycle. We talk about that, have respectful conversation among ourselves about the best way to achieve a goal. I think everybody would agree to. With that, let me kick it over to you. There are lots of hands up. Are we circulating a microphone? Okay.
Just shout it out. Repeat it.
Okay, yeah. Gentleman in the purple, I'm told, was the first. Which gentleman?
Yeah, you.
Okay. I have a hard time seeing you here.
Governor, when you created the Colorado exchange, were you able to appropriate any state funds into that reinsurance pool or for marketing or in any way to subsidize premiums lower? State money.
So we didn't do that. We did it indirectly in a couple of ways, but in a very modest format. The structure of the system allows you to have reasonable marketing dollars. I don't think that within the expansion of the Affordable Care Act in and of itself, but we didn't subsidize that to a large extent, or at least I wasn't aware of it. We discussed that in the beginning. Our goal was to try and be as restrained in terms of spending state dollars. Obviously, we still had to, as we expanded Medicaid, there is a state portion of it. The first couple of years was quite low, but then it grows each year. And we accepted that responsibility just for the benefit that it brought us. But we didn't want to go beyond. Trust me, we got our Medicaid expansion done in a bipartisan method, and that was no joyride.
The gentleman in the purple shirt in the last row, sorry. Please go ahead.
Governor, I'm a former Colorado citizen. I graduated from Windsor High School in Windsor, Colorado in 1997. I've been here in Iowa, a transplant here in Iowa for 10 years now. The issues that I hear you folks talking about today, one of the things brought up is that the ACA has been fought against for 10 years now. And my opinion is we don't know how to fight back. It's very easy to fight back against. You folks are talking about nickels and dimes. All you have to say to the American public, our option will not bankrupt you. That's it. And you have to hold that in your heart and take it into consideration. And then you will win the fight. You cannot be talking about nickels and dimes. You have to say, we will not bankrupt you. Because in this country, most recently, I'm not sure if you saw this, but there was a Canadian couple who was traveling in Florida. Their I believe their father-in-law passed away. He was 80-some years old. On the car ride home, they decided not to take him into the United States healthcare system because they were afraid of the cost. They wanted to travel back to Canada and deal with the Canadian health insurance system. That is what we're dealing with. We cannot bankrupt people when it comes to healthcare.
Fair enough. I think one of the things that was largely unreported, but as a consequence of just the Affordable Care Act, which was not universal coverage, but the rate of bankruptcies in Colorado, I don't have the exact statistic, but I believe it was almost 50% drop from 1 year to the
I think that's really close.
It was a huge drop in bankruptcies. People did not recognize just how large a percentage of the personal family bankruptcies were caused by healthcare issues.
Let me just recognize Betty Judge, former Lieutenant Governor, our good friend, who's joined us. I didn't see you first, but great to have you here.
Connie Bozen is here also on the Des Moines City Council. I just wanted to just
Thank you. Okay, well, I had somebody, I'll get to you next, but this lady here, please.
Hi. One main thing I want to ask. How do you justify a profit motive moving forward? We are just losing another MCO here in Iowa for Medicaid, but we've also had the same problem with some of our just, regular insurers, huge CEO salaries, just outrageous amounts of money going out the door for administrative costs. How do you rein that in? Because if we're going to move forward with a plan that's anything but Medicare for all, that's going to be a factor. And I heard you say something, Governor, about a profit motive in rural areas. And that just stabs me in the heart because I know how many problems we're having that here in Iowa. So could you please answer, how do you justify a profit motive moving forward?
Well, I think the hard issue here is how do you go backwards? In other words, you look at I grew up in the 60s, right? I protested, I marched for the Civil Rights Movement, I protested the Vietnam War in Washington. I'm as idealistic as the next person. But it's hard once the genie's out of the bottle. If you look at some of the other systems around the world, Germany is a good example, right? They have a whole number of insurance companies, and they're all nonprofit, right? And that's a large part of their success, is that they have taken that aspect, that component of cost out of it. I mean, this is the amazing thing. If you look at what our cost as a percentage of our GDP is, we're pushing up against 18%, whereas the average of all the other industrialized countries is 10.5%, I think 10.6%, something like that. So profit's not the only reason that is. We can go down a long list of things, but if you're going to nationalize all those insurance companies, just tell them they no longer have a business and that their employees are all unemployed, there's got to be a process by which you do that. And that's where I think allowing a public option by which people can move into Medicare or into Medicaid, and if it works and is successful, it'll happen rapidly. I think that's a much more American way to transition than trying to have a revolution.
I would just add that, one answer to your question is price regulation. I mean, that's how everybody does it. It doesn't, you don't have to abolish all private companies in order to get prices under control. Yes, sir.
Yeah, I actually just this summer had a significant medical experience. I'm actually a retired physician, and I was in the hospital for over 5 months for 27 days with 7 operations, and my medical bills were $400,000. But the insurance company paid the hospitals and the doctors $66,000, and they were happy with it. And yet, if I didn't have insurance, if I was a year younger, and I didn't have Medicare, and I didn't have insurance, I would have been responsible for that whole $400,000. And the problem is that's where a lot of the medical bankruptcies are coming from, not because they can't afford it, but because they're being charged 8 to 10 times what the insurance companies are paying for the exact same care. The other point I just want to make is that there are two things that would really improve the economics of medicine in the United States, and that's one is to reverse the 2006 congressional bill that made it against the law for the government to negotiate with pharmaceutical companies, and also to say to the medical, like the total hip replacement companies, that you can't charge us 100 times more for the same hip replacement here than you charge for the hip replacement in India. So I'd like to see what you think on those two things.
What is your name?
Dr. Kozlow. And by the way, I just want to introduce Dr. Mrs. Claire Celsi, Senator Claire Celsi, one of our newest senators who I asked the last question.
Welcome, Senator Celsi. We know very well. I just want to add one little story to follow up with your comments, Doctor. As I would move around the district, Q&A time was always a lot of fun. But really to understand what people needed, I would often ask, if I serve you in Congress, what is the first bill you would like me to drop? How can I help you the most? Hands down, change the 2006 law so we can negotiate for prescription drug pricing. Right to your point. It came up over and over and over again. So thanks for bringing that up.
Yes, sir. Back row here, please.
Yes, I'm Jason Ferris. I have a decade of clinical experience in respiratory therapy that was at 25 rural hospitals in the United States, 49 Iowa, now in Lincoln, the largest community in the United States of America. I'm going to be honest, I came here very skeptical, and I'm even more skeptical than I came. I will not support presidential candidate that does not favor the crap out of healthcare, because I'm sick and tired of banging my head against the wall to get my patients things they need because the insurance company says, oh, well, no, you can't get that because you didn't cross your eye. I mean, if we do not remove profit, we're all going to go bankrupt. And are any of these folks clinicians? I'm curious. And so that's a huge problem with healthcare. We have people who aren't clinicians telling us how to run healthcare. That's a problem.
Blue shirt, sir?
The one question or suggestion I would have is, we know how much money is tied up in the financial reserves for these health insurance companies. Because someone told me it's close to $7 trillion. If there's $7 trillion in financial reserves in these health insurance companies, there's a way to transition out by using that money to buy out their firms. These people also have, these companies also have close to 600,000 employees working for them, don't provide one scintilla of health care to anyone. And there are also 325 to 350,000 health insurance agents that get renewal checks every month off the Medicare Advantage plans they've sold, off the Medicare supplements they've sold, off group insurance they've sold. These are some of the areas that we really need to take a close look at to figure out how we can call those costs out of there and pare this down so it is more affordable.
I mean, that's why we support more price regulation. And one of the things that the ACA did is it implemented MLR rules, which is medical loss ratio rules, which meant that the insurance companies had to spend 85% of their revenues on healthcare, or they had to send a check back to their customers. Again, not a perfect system, we still have problems, but I think that there's a lot of things that we're working in that direction, because you're right, there is too much money and healthcare needs to be affordable.
Yes, sir.
My name is Davis. I come from Warren County. I'm on disability on Medicare. I did run for county supervisor. Got 43% of the vote my first time out. But I'm facing a problem right now where I took a fall about a month ago that aggravated an old problem that made me disabled. And beyond the point, the doctors, my primary care physician, the people that did the MRI, everybody is saying that beyond the point of physical therapy and pain medicine, that I have to have a neurological surgery to correct the problem in my spine. therapy and pain clinic before we'll even consider this, even though I've already done this stuff. That's where our problem is. I mean, as Jason said, we have non-clinicians telling doctors how they're going to treat the patients.
Yeah.
And tying their hands.
Do that?
Yes, ma'am. You've been patient, thank you.
Yeah, so thank you for being here today. I don't have a ton of great numbers and statistics like some of these people who are much smarter than me do, but I have my story. I'm a 35-year-old woman. I've had type 1 diabetes since I was 3. And through the years after I graduated from college, I couldn't get on health insurance because of a pre-existing condition. And because of that, my husband and I now have tens of thousands of dollars in medical debt. We can't afford to buy a house. We can't travel. We have to nickel and dime our budget every single day. So on the one hand, you have people who can't afford their medications. It's affecting economic growth. You know, it's affecting our choice in whether or not we want to adopt children in the future. And then you have these health insurance companies and these pharmaceutical companies like I believe Novo Nordisk and Cigna both said we're going to cap it at $150 per month for your insulin. I know before I married my husband, when I was a journalist, when I was with like PR agencies, I still couldn't afford $150 per month for my insulin. I was skipping insulin doses to the point where I was in the hospital all the time. So like the gentleman in the red shirt says, there's a lot of money coming in from the pharmaceutical companies, from the insurance companies. How do you get rid of that? How do you place caps that are actually affordable for people? Not $150 per month. There's so many sides to this issue, and clearly this is something that has affected me my whole life. My parents would have to choose between paying the electricity and my medicine. So, if not universal health care, what do you do? Not everyone is going to get as lucky as me, where I have a wonderful, caring, supportive husband and a caring family to get the medicine they need. So, like, what is your proposal? And like, we need it sooner rather than later, because this is affecting my everyday life and my choices with my husband.
And I could not agree more. I mean, part of this is the pharmaceutical companies have a stranglehold on the prices they fix to the customers in the United States. And I think if you looked at what someone's paying in Canada, these numbers it was told me are between 1/30th and 1/20th of what you're paying. So if you're paying $150, you would be paying $10, right? Or maybe even less than that in Canada. There's no reason why we shouldn't be able to have that same pricing here. And I could not agree more. I'm not sure, and again, trying to create, trying to go instantaneously to a single payer system, even if it were possible, would automatically solve that problem. You're still going to have all the costs and the pressures. But there is no reason why something like insulin that was created in this country, why we should have to pay a premium. Every single man, woman, and child in this country who uses insulin is paying more than anyone else in the world is paying. And I think Will was right when you say that the government regulation is the only way you're going to get to it. And I will tell you also that this is not just in healthcare. I talked to a guy 2 months ago, and I was unaware of this, but there are 81,000 trade associations in the United States. And these aren't evil people, right? The trade association, Sand and Gravel Association, the Sheetrock Association, the Electric Motor Association, the Sneaker Association. There are 81,000 associations. Every one of them has a lobbyist, right? And every one of them is trying to get an advantage, either a tax break or a pricing protection. Everyone's trying to get an advantage for their industry. And no one, I mean, we have slowly over time, no one is sticking up for the American people, and no one's shining a light on exactly how widespread the function is, right? 81,000 trade associations, right? And again,
think about it, if everyone has at least one lobbyist, and obviously some lobbyists work for multiple trade associations, but that's a huge number of people trying to get either a tax break or a price protection, and there's no one really organized to stand up against them.
I think I've been given the hot side here that we've run the limit of our show here today. It's too bad because there's lots of great questions. I'm sure I can see we still have some more, but I do want to just give everybody a final chance to comment here on the panel before we close this, and perhaps you can have a chance to put your question to one of our folks here after we shut down.
Again, I'm going to speak to you from someone who decided to run for office. Thank you for sharing your story. And I encourage all of you to get out there, run for office. I don't care if it's library board, I don't care if it's for president. But if you feel passionate about this issue and others, get involved. We were fortunate enough to stave off the collapse of the ACA with the Republican Congress, but we know right here in Iowa where we have lost a seat at the table with the House and the Senate and the governors all being held in the Republican hands, the devastating effects it's had on Medicaid here in the state. And I know we're not here to talk about that, but these are the stories and the lives and how it's affected people's lives here in Iowa. Get involved, support your candidates, donate up and down the ticket. Local elections are just as important as our presidential elections. And then win, lose, or draw, thank your candidates for running. And I do thank you for coming out today and sharing your stories and perspectives.
So I'll go next to the governor can
Good.
I just want to say, thank you all for coming and giving us your comments. I think, this is why I've pursued this career, and it's just so great to be in Iowa and hear all of your stories and your experiences, and I know that we can and should do better, so thank you.
And I especially want to thank everyone for their stories. Healthcare is something that more than any other single issue exposes the underside of where America isn't working, and that only comes into sharp focus from those individual stories. I will say the only way to really fix it is through the ballot, through the elections, and I think we have to take a long, thoughtful look. I don't always get a lot of people to agree with me, but I think as Democrats, we should commit ourselves to the notion that healthcare is a right and not a privilege, and that's going to be our banner, and that whoever wins that nomination, we should be universal to support them, because no matter what pathways we choose to embrace, we need not just the White House, but we need both houses of Congress. You're never going to get anything done without that kind of support, and that's going to require a very large cross-section of American voters. Again, I appreciate all of your stories. I mean, when I first got elected mayor, I got involved basically because of the homeless issues. I owned a bunch of restaurants in Denver, and I got to know a number of the chronically homeless, and was very frustrated by government's inability to deal with them. And their medical issues were a huge part of that. At that time, and this is 10 years ago, 12 years ago, a chronically homeless individual, by the time they showed up at the emergency room of a hospital, the average care per visit was $28,000. This is in 2007, 2008. The cost, when you added all the services that the city and the state were spending on the chronically homeless, it worked out to north of $40,000, $44,000 per person per year to perpetuate lives of misery. A large part of that was healthcare, but not the whole thing. We were able to make some pretty significant changes in healthcare by, getting a city council in place and building an alliance, a
collaborative forum between the local government, local business, and the nonprofits. And ultimately, long-term, we're really going to fix healthcare. It's going to be that kind of a collaborative solution where you get the nonprofit community, the foundations, everyone trying to find where the best innovation is in collaboration with the small businesses, with all businesses, but then also with government. The fact that you're all here says a lot about your willingness to be part of that effort. So again, thank you all for being here.
Thank you,
Will.
Thank you, Joe. I just end with this one note. It's like really a plea. Recall what's in the first paragraph of that description of the PPI's approach. You know, there's a clear choice in this country between a party that wants to cover everybody and wants to drive the cost curve down so we can afford to do that, and a party that just doesn't want to cover a lot of people and in fact wants to roll back coverage to take it away from people that already have it. And I hope we keep that division in mind rather than our own disagreements, which we'll have within our own family, over the best way not only to construct a sensible answer to all the problems that we've heard about today, but to get the American people to support it, because in the end we've got to build majorities that are going to continue the momentum to a universal, affordable, innovative healthcare system that covers everybody. So with that thought, thank you all for coming, and thanks particularly to our wonderful speakers for being here today.